Okay, let's jump straight into the deep dive. We got some really interesting source material today, shared by a listener. It's revision notes focusing on a specific medical condition,
Mm.
something you might see if you're studying hard, maybe for the MSRA. The
Mm.
topic, Chondrodermatitis Nodularis Helicis.
Right, CNH.
Yeah, CNH. So our mission really is to take these notes, unpack them,
Yeah.
and make them super clear, memorable, uh, really high yield for revision. Or, for anyone curious about these things.
Exactly. And sometimes these seemingly less dramatic conditions are actually vital. They test observation, differentiation, understanding the details of even, well, common discomforts. This deep dive is all about pulling out the key bits from the source material on CNH.
Okay, let's unpack it then. What is Chondrodermatitis Nodularis Helicis? The notes define it as a benign inflammatory condition.
Benign inflammatory. Got it.
And the key thing, the characteristic that stands out in the source, it's a painful nodular ulcer, a very specific location, the helix or antihelix of the ear.
Yes, that pain is absolutely key. It's not just some bump, it's inflamed. And the source clarifies it involves both the cartilage and the skin.
Ah, both layers.
Both layers of the ear's pinna, the outer bit. And the pain is really a hallmark. The notes also mention other names you might see. Ear pressure sore.
Ear pressure sore.
Or
Sounds
Winkler's
like
disease. So yeah, common, benign, but definitely painful, involving skin and cartilage. Remember that.
right, painful ear nodules, skin, and cartilage.
Mhm.
So where does it come from? What does the note say about the etiology, the cause?
Well, like a lot of things, the source says the exact cause isn't totally known,
Okay.
but it lists factors thought to contribute, things like pressure on the ear.
Makes sense with ear pressure sore.
Yeah, exactly. Minor trauma, reduced blood flow, ischemia, and even sun exposure comes up.
Sun exposure too.
And what's interesting is how the notes link these factors to the ear's actual anatomy. The source points out the pinna has, well, limited subcutaneous tissue.
Not much padding.
Not much padding, right? And the blood vessels in the skin there are pretty small. So the idea is, once there's some damage, maybe from pressure, a knock, these features make it harder to heal properly.
Okay, that collects.
They even mention possible changes in the tiny arteries near the cartilage, perichondrial arteriolar changes, and surprisingly, they suggest autoimmune factors might play a role sometimes.
Wow, so potentially more complex than just a simple pressure thing.
Could be. Pressure might be the trigger, but the underlying mechanics seem a bit more involved according to these notes.
Okay, so given those potential causes and the ear's structure,
Mm-hmm.
who tends to get this? What about risk factors? Epidemiology.
The notes list the typical risk factors, more common in men,
Ah.
tends to affect older individuals more, and crucially, linking back again, prolonged pressure. That's a key trigger mentioned.
Like sleeping position or headphones.
Exactly. How you sleep, headphones, maybe even phone use. Sun exposure and smoking are also listed as contributors.
Okay, and the bigger picture, epidemiology.
Fits with that. More common in middle-aged and elderly adults. The source does say specific UK prevalence data isn't well established,
Right.
but it can affect really all ages, genders, skin types. Now, here's a really specific detail from the notes, great for revision.
Right.
The source notes it's often localized to the helix in men
Helix in men?
and the antihelix in women.
Oh, interesting. That's specific.
Yeah, it's a neat observation in the notes, potential clinical clue right there. And yes, that pressure link is definitely hammered home as a major trigger.
Helix in men, antihelix in women. Got it. So if pressure or trauma gets things going, how does it actually, develop a pathophysiology?
The notes keep this part fairly straightforward. It focuses on the main mechanism. The thinking is that repeated microtrauma and that pressure disrupt the blood supply.
Right, to that specific bit of the ear.
Exactly. And what happens when you disrupt blood supply?
Ischemia, lack of oxygen.
Precisely. Ischemia. This leads to tissue damage, inflammation, and eventually that characteristic painful nodule forms. So pressure leads to reduced blood flow, leads to damage and inflammation. Clear pathway.
Simple enough to remember. Pressure, ischemia, nodule. Okay. Now, this is super important for revision and, well, for diagnosis. A painful ear nodule. What else could it be? What differentials do the notes list?
Yeah, this list is absolutely crucial because you have to rule out more serious things that can look similar at first glance.
Right.
The source gives quite a list. Basal cell carcinoma BCC,
Common skin cancer.
very common. Squamous cell carcinoma SCC, another big one. Auricular perichondritis, that's inflammation around the cartilage. Pyoderma gangrenosum, a rare skin thing. Keratoacanthoma,
Grows fast, looks like SCC sometimes.
Exactly. Actinic keratosis, that precancerous sunspot, elastic nodules of the ears, benign sun lumps, and cystic chondromalacia, which is cartilage degeneration.
That's quite a lineup indeed.
It is, and the notes are really clear which ones are the absolute must-distinguish ones.
The cancers, I assume.
Yep. They explicitly say a skin biopsy is the way to specifically exclude BCC or SCC if you're uncertain. So even though CNH is benign, you've got to keep skin cancer on your radar, especially with that sun exposure link.
Okay, that's a huge takeaway. Always rule out the nasty stuff.
Yeah.
Do the notes mention any associated conditions?
They do. Generally, CNH itself is benign, right? But the source notes a potential link with broader immune-mediated vascular issues.
Blood vessel problems tied to the immune system.
Sort of, yeah. And conditions involving collagen breakdown, like granuloma annulare, especially in younger people, and maybe most relevant clinically.
Go on.
The notes point out that patients with systemic sclerosis and primary biliary cirrhosis, sometimes called Reynolds syndrome together, they have an increased risk of skin cancers like BCC and SCC.
Ah, so if you see an ear lesion in that patient group.
Your suspicion for cancer needs to be even higher, according to the source. It's a really valuable connection to make.
Definitely. Okay, long differential list. Rule out cancer first, especially in some groups. So let's get back to CNH itself. What does it look and feel like? Clinical features.
The classic picture, as we said, is that tender or painful nodule, sometimes an ulcer, location, helix or antihelix, and the key symptom. Pain gets much worse with pressure or touch.
Like lying on it? Headphones?
Exactly. Lean on it, wear headphones, sleep on that side, ouch. The notes add a bit about the history, too. Usually pops up spontaneously, might grow fast at first, then kind of stabilizes.
And triggers can be pressure, trauma, even cold.
Yes, all mentioned as potential triggers in the notes. And the physical signs described are really specific, helpful for ID. Typically, it's a single nodule.
Just one.
Usually just one. Most commonly on the outer rim of the helix, often right at the top curve, the apex. Though remember that helix-antihelix difference, too. When you touch it, the notes say it's firm, very tender, and well-demarcated clear border. Size varies, maybe 3 to 20 millimeters. Average about 6 millimeters, the notes suggest. Round or oval, slightly raised, and importantly, firmly attached to the cartilage underneath.
Stuck to the cartilage, not just skin deep.
Exactly. You can't just slide the skin over it easily.
Yeah.
That's a good clue. The surface might look inflamed, maybe scaly or crusty.
Crusty.
Yeah, and the notes mention if you were to remove that crust, you might see a small raw spot or even a central core. Other signs listed just recap: localized pain, tenderness, erythema, redness, maybe some swelling, crusting, scabbing. Those are your visual and touch clues.
Okay, that's a really clear picture. So we know what it is, causes, who gets it, what it looks like, what else it could be. How do you actually confirm it? Investigations.
The source is pretty straightforward here. Diagnosis is primarily clinical.
Based on history and exam.
Yeah. In many cases, that story, painful nodule, worse with pressure, typical spot, plus those signs we just talked about, that's often enough to make the diagnosis confidently.
But sometimes you need more.
Sometimes. The notes say a skin biopsy may be considered if the diagnosis isn't clear-cut, and like we discussed with the differentials.
To rule out cancer.
Exactly. The main reason for biopsy, per the source, is to help specifically rule out basal cell or squamous cell carcinoma. So, trust your clinical skills first, but biopsy if there's any doubt, especially about malignancy.
Got it. Clinical first, biopsy if unsure, mainly for cancer. Okay, let's switch to management. Someone has CNH based on these notes. What are the treatment options listed?
The notes give a good range, starting with conservative stuff.
Right, the simple things first.
Yeah, and the source says these are often effective, which is good news. The main idea is just reducing pressure on that spot.
Makes sense. How?
Well, the notes list practical things, foam ear protectors or special pillows with a hole for sleeping.
Donut pillows.
Kind of, yeah. Changing how you hold your phone or wear headphones. Simple things like corn plasters might help, or custom devices. Even protective silicone splints get a mention.
Anything else conservative?
Avoiding cold and too much sun exposure is advised. And topical antibiotics if it gets infected or ulcerated. It's all about tackling that main trigger pressure.
And if those don't cut it?
Then the notes list more medical and procedural options, things like topical nitroglycerin.
Nitroglycerin, like for heart conditions.
Yeah, surprisingly, the notes say it can help with pain and appearance here.
Yeah.
Also, topical or injected steroids right into the nodule for the discomfort.
Okay.
Other procedures mentioned are cryotherapy, freezing it, using lasers, CO2, or argon are named, or photodynamic therapy.
Lots of options. And surgery.
That's the last resort if nothing else works or it's really bad. The notes describe surgical techniques, and the key point is they generally involve removing the affected cartilage.
Taking out the bad bit of cartilage.
Essentially, yes. Techniques mentioned include cutting out the cartilage and reconstructing the skin, or a narrower excision shaving down the cartilage, or even a punch biopsy going deep, which might need a skin graft. So, yeah, quite a spectrum from just avoiding pressure to actual surgery.
That's comprehensive.
Yeah.
Treatment options covered. What about the long term? Prognosis. What do the notes say?
The source describes CNH as chronic. It tends to stick around.
Comes and goes.
Often, yeah.
Yeah.
Periods of remission where it's better, then exacerbation where it flares up. But the really crucial point about prognosis from the notes, it is not life-threatening.
Okay, that's important. The benign.
Definitely benign. And they also say most cases are managed effectively with those conservative pressure-reducing steps.
Good. But surgery, does it always fix it?
Not always. The source notes that recurrence is possible after surgery.
Oh.
Yeah, they even give a specific recurrence rate range in the notes. Somewhere between 10% and 30%. That's a number worth remembering, perhaps.
10 to 30% recurrence after surgery. Okay.
Right.
So even surgery isn't a 100% guarantee. Lastly, then, what problems can crop up? Complications.
The notes list a few main ones. Superinfection, getting a bacterial infection on top. Crucially, and we touched on this, chronic pain is listed as a complication. Despite being benign, the pain can be persistent and really impact quality of life.
Yeah, that sounds rough.
And the notes also mention scarring and potential cosmetic disfigurement, especially if the nodule's big, hangs around, or needs surgery.
It really shows that benign doesn't mean insignificant for the person experiencing it. Chronic pain, scarring, those are major.
Absolutely. It can cause real, genuine suffering.
Wow. Okay, we have really gone through Chondrodermatitis Nodularis Helicis in detail here using these listener notes. Covered the definition that painful ear nodule, triggers like pressure, the anatomy involved, that crucial differential list, the management from simple fixes to surgery, the chronic but benign outlook, and those complications like pain.
And that's the benefit, isn't it? Taking notes like these and actually talking them through. You connect the dots, etiology to anatomy, differentials to investigations. It helps solidify that high-yield info, makes it stick. You know, given that CNH is described as benign, but often chronic, painful, significantly impacting quality of life, maybe even causing disfigurement, it does make you think, doesn't it? It kind of raises an interesting question for you, the listener, to mull over. How do we perceive, prioritize, and, well, treat conditions that aren't life-threatening but still cause significant long-term suffering?
Yeah.
How much weight do we give to that impact on quality of life?
That is a really powerful thought to end on. Thank you again to the listener for sharing the source material for this deep dive.
Yes, much appreciated.
And if you are listening and studying maybe for the MSRA or similar exams, getting hold of good, clear, high-quality revision materials is just so important, making that study time count.
Absolutely key.
So if you are looking for resources, we definitely suggest checking out passmsra.com. They're designed specifically to help with this kind of focused revision.
Good resources to know about.
Right. Well, that's it for this deep dive. Thanks for joining us. We'll be back soon to unpack the next set of source material. See you then.